My name is Ayman Sayaldin. I'm one of the chief residents in St. Mary's Hospital in Waterbury, Connecticut, and I'm happy to be joined today by Dr. Maura Marcucci from McMaster University in Ontario, Canada, on behalf of the BOYS 3 trial investigators. Dr. Marcucci, thank you for joining us.
Thank you for having me.
Why don't we start by telling us where the research idea came from and how did the trial design come about?
Thank you. Okay, so in BOYS 3 blood pressure trial, we wanted to answer the following question. So in patients coming for non-cardiac surgery, for an inpatient non-cardiac surgery, a risk of vascular complications, and taking chronically at least one antihypertensive medication, we wanted to compare the effects of a hypertension avoidance strategy versus a hypertension avoidance strategy perioperatively on their effects on major vascular complications 30 days after surgery. And the reason why we want to answer that question is that we know that many of these patients coming for non-cardiac surgery experience major vascular complications. And we also know that hemodynamics abnormalities, and in particular hypertension, are frequent and they are associated with vascular outcomes and also all-cause mortality. So we wanted to compare these two strategies that we call hypotension avoidance and hypertension avoidance based on the blood pressure abnormality they preferentially intended to avoid. And the way they would do that is that targeting two different blood pressure targets intraoperatively, the hypotension avoidance would target a MAP of 80 or greater. The hypertension avoidance would target a MAP of 60 or greater. And also the two strategies differ in terms of how to administer the chronic antihypertensive medications of these patients preoperatively or postoperatively. In the hypotension avoidance, patients' chronic antihypertensive medications were managed according to an algorithm. In particular, ACE inhibitor ARBs were held preoperatively and postoperatively, and the other chronic antihypertensive medications were continued only based on the blood pressure of the patient. While in the hypertension avoidance strategy, all the chronic antihypertensive medications was just continued perioperatively.
That's perfect, because I'm guessing there is a lot of variance between practitioners on holding ACE or ARB or beta blockers, so I'm glad there was an algorithm on how to do this in a trial.
Yes, that's true. So really, when we started the trial, prior studies, observational studies demonstrated that people tend to continue their antihypertensive medication, their chronic antihypertensive medication perioperatively, even with some variation across practice. And it's absolutely true that involved also whether ACE inhibitor ARBs were held and whether beta blocker were held as well. Yeah.
And I'm curious, with this strategy and algorithm, how did the outcomes, what were the results that you found?
So unfortunately, we did not find any difference between the two strategies on major vascular complication, which was our primary outcome, a composite of all-cause mortality, of vascular mortality and non-fatal myocardial injury, non-fatal stroke, and non-fatal cardiac arrest. And we did not find any difference also on other clinical outcomes, including single vascular outcomes, all-cause mortality, and, for example, other outcomes like congestive heart failure around the time of surgery.
Okay. I'm curious, was there any subgroup analysis between different antihypertensive medications like beta blockers or ACE or ARBs?
We did specify a number of subgroup analyses, and one of them was, in fact, whether the strategies differ, so whether our primary analysis differed based on whether patients were chronically on ACE inhibitor or ARB or not, or whether patients were chronically on a beta blocker or not, because as you can imagine, not everybody was on an ACE inhibitor, ARB, or a beta blocker. And unfortunately, we found that our primary results, so no difference between the two groups, were consistent across different subgroups, so even in patients that were chronically on ACE inhibitor or beta blocker.
And I'm curious, how does this tie with the BOYS trial that was published in 2008 that found, there was a lot of death and vascular complications with beta blockers? Do you have any insights on that?
So thank you for the opportunity to compare these two trials. So one important difference that I have to outline between the two trials is that in BOYS 1, patients were naive to beta blockers. So it was a new beta blocker started around the time of surgery, while here the BOYS 3 trial tried to understand how to manage differently the chronic antihypertensive medication these patients were on. But BOYS 1 results are still very important to us, because BOYS POISE 1 really demonstrated if you have an intervention like a new beta blocker that is having an impact on hemodynamics. In POISE 1, there was an important difference in clinically significant hypotension and bradycardia between the two groups. Then you see an effect on vascular outcomes. What we experienced in POISE 3, when we looked at the effects on hemodynamics of the two strategy, we did not find a substantial difference in systolic blood pressure and heart rate between the two groups. So very likely, we did not see an impact on vascular outcomes because we did not see a huge impact on hemodynamics when you just play with the chronic antihypertensive medications of these patients.
That makes sense. And lastly, what do you think the impact or the effect of this trial on the clinical work, and how do you see this changing the practice?
So POISE 3 really informs two important questions that confront physicians that are taking care of patients coming for non-cardiac surgery every day. So on one side, one answer is that if you target a MAP of 60 or greater, or you target higher MAPs intraoperatively, you don't see a great difference in vascular outcomes. And then perioperatively, if you hold this inhibitor ARB and continue the other antihypertensive medication based on algorithm, versus just continue all the chronic antihypertensive medication, does not have an impact on hemodynamics and eventually vascular outcomes. So we can keep in mind these answers now when we deal with these patients. One thing that we have to remind, a couple of things that we have to underline here. On one side is that we didn't find a specific subgroup effect. So I cannot say, okay, this strategy works in this specific subgroup. But it's very likely that on specific individuals, the common sense still plays a role. So it's possible that a hypotension-avoidance strategy still works in some specific individuals. And on the other side is that POISE 3 is not showing that hemodynamics, and in particular hypertension, doesn't matter. It was not experienced enough in a different way in the two strategies. So it's possible we have to continue to look for perioperative interventions that might have an impact on hemodynamics to the extent and in the direction that will eventually impact on clinical outcomes.
That was excellent. Thank you so much, Dr. Marcucci, for finding the time to talk with us. Thank you.
Thank you for the opportunity.